Assalamu alaikum. Good evening. Welcome to our webinar, Medication Without Harm. Actually, we are so lucky to have our speaker today. She is one of the first assigned medication safety officer in King Faisal Specialist Hospital and Research Center, one of the first holding this position in Saudi Arabia or on the Gulf Region Hospital. She is also holding the credit of successful initiation and progress of medication safety services in King Faisal Specialist Hospital and Research Center. She is also the founder and the director of Medication Safety Officer Preparation Courses, and she is training hundreds of medication safety officers in Saudi Arabia and the Gulf region countries. Dr. Salma Al-Khani, she got her bachelor degree in pharmacy and master degree in health and hospital administration from King Saud University. Then she completed the medication safety patient program in the Methodist Hospital in Houston, Texas, on April 2009. In addition to the medication safety training program in Prime and Women's Hospital, Boston, US, on October 2011. Welcome with me, Dr. Salma. Dr. Salma, the floor is yours. We can start.
Thank you, Nov. Thank you, everybody, for the invitation. I'm really very happy and thrilled to spend the coming hour or 1.5 hours talking about medication safety. As I think everybody knows, medication safety is my passion, and I'm sure it's everyone's passion who's attending with us the webinar today. So to start, after this great introduction, I would like to welcome all our audience, our guests who are interested to learn more about medication safety. I would like to thank the Saudi Patient Safety Center, the WHO Center, for allowing me to sit with them today and share my experience and share some thoughts about safe medication practices and the initiative of medication without harm. So these are my learning objectives at the end of the session. I'm expecting the participant to be able to know the definition of polypharmacy, to understand the risk factors of polypharmacy, to understand the importance of medication reconciliation process and its implementation strategies, and to recognize the physician, pharmacist, and the nurse role in this process. So let's start with medication with no harm. Both patients and healthcare providers has a role to play in ensuring safe medication practices. We cannot ensure safe medication practices by one profession or by healthcare without involving the patient. So we need to work together as a team in a healthcare system, a pharmacist, a nurse, a physician, along with the patient themselves, to make sure that they have receiving the highest level of patient and medication safety. That's why the WHO, the third Global Patient Safety Initiative, they came up with the idea of medication without harm. The WHO has developed a campaign to increase public awareness of the safety issues related to the medication use. Since WHO noticed the importance of safe medication practices and the harm coming from medication errors, they came up with this campaign idea, and it was launched as a global patient safety initiative. The WHO aimed to develop strategies for safer medication practices to reduce the risk of polypharmacy and the transition of care through a medication reconciliation. So let's start with the definition of polypharmacy. I know there's multiple definitions for polypharmacy, and in each area of the world or each organization, they have their own definition of polypharmacy. But now we will be using this definition. The definition would be polypharmacy is the routine use of 4 or more over-the-counter prescription and or traditional medications. And I would like to focus on the word routine use. It has to be routinely used, not for a specific period of time and when we stop, and then we stop it. And it has to be used all together at the same time by the same patient. So polypharmacy can be with any patient, can be with any one of us, but it is more common in older population or in old age patient. Polypharmacy by itself, if everything went correct, it increased the risk of multiple unforeseen or unpleasant outcome. I can say it will increase the risk of side effect, medication side effect. It will increase the risk of drug-drug interaction because more medication you use or the patient use would put him under the risk of more drug-drug interaction between these medications. And there is a possibility of reduced adherence. If you have to take more than one medication, or if the patient needs to take more than one medication at different time, at different schedule, there is a possibility that patient will not be adhering to using this medication as it was prescribed or as it was intended. So there is multiple risk factors for polypharmacy. The risk factor vary between one patient to another, between one situation to another. Those risk factors can be divided into two types of risk factors: patient-related risk factors and healthcare system-related risk factor. Like, for example, for the patient-related risk factor, if the patient is an elderly patient, some organization define it as more than 62 years old patient. The patient could be with cognitive impairment. The patient would have developmental disability. They might lack a primary care physician access. Maybe they do not have a primary care provider, so they can discuss their treatment regimen with them and ensure compliance and correctness of treatment regimen. They might be having some mental health condition. They might be having some chronic condition, multiple chronic condition that might interact together, diseases together and medications together. Residing in a long-term care facility, those patients who are residing in this long-term care facility, they are prone for more medication-related adverse drug event than other people taking care at home properly. And then being seen by more than one subspecialty. And you would ask me why this would be considered a risk factor, because each subspecialty will see the patient, will prescribe him some medication, and they might not notice that he is taking similar medication or some interacting medication by other subspecialties. And you will end up having, as I mentioned earlier, more drug-drug interaction and more side effect. So those were the patient-related risk factor. What about the healthcare system-related risk factor? I can say that poor medical record keeping, poor documentation. I don't know what was the patient receiving before. Did he had any adverse drug reaction before? Does he have any allergy? All of these documentation would be lacking if the hospital does not have a strong medical record keeping. Poor transition of care. If the patient will be moving from in to outpatient, from out to inpatient upon admission, moving between different levels of care, if this is what not properly designed and documented, medication errors and misadventures would happen. Then prescribing to meet disease-specific quality metrics. So if I'm looking for a specific number with these diseases, I might end up having improper medication management. Then use of automated refill system. Automated refill system that automatically the medication will be refilled to the patient without a proper clinical assessment and being seen by a physician. So automatic refill, it's an open-end prescription to the patient, whether he really needs the prescription or he does not need the medication of this prescription. So all of these are considered a risk factor for patients under polypharmacy. So there is a very important question. We always remind our patients to look at it when they've been prescribed or when we are prescribing a new medication to the patient. So before starting any new medications, we need to ask, are there underlying causes that should be addressed first? Maybe there is other reason that I need to address it before I start prescribing medication to the patient or dispensing a medication to the patient. Is there a new medication treatment necessary? Is it really very important to take it, or it is not a necessity for this specific patient? Can be managed by different non-pharmacological approach. And this is now we need to focus on the non-pharmacological approaches of managing diseases. Are there any preventive measures that can be tried first? Can we prevent the disease in any means before start, like using some lifestyle modifications, some eating habits modifications before I start the patient on the diabetic medication or some antihypertensive medication when it is really not desired or not needed? Are there benefits from using this medication? Are there proven outcome that this will help the patient to overcome this disease or minimize the impact or the signs and symptoms of the disease? When will the benefit be seen? Am I expecting this to be seen very soon or after several, like a specific duration? What are the risks? Am I aware clearly about the risk coming with this treatment regimen? Am I looking for some risk mitigation strategies with this medication? What are the patient's caregiver goals of the therapy? Do I know why am I giving this medication? I'm giving warfarin. Do I have a target of my INR? I'm giving heparin. What am I looking for? I'm giving pain medication. I'm giving antihypertensive medication. What am I monitoring while starting these medications to the patient? Do I have a specific goal I need to reach, or I'm just prescribing it generally without a clear goal and parameters in mind? What is the patient's estimated life expectancy when considering age and comorbidities? As I mentioned, polypharmacy is a very high risk contributing factor for elderly patients. And if I have an elderly patient that I start to prescribe him some medication, what is my expected life expectancy? Would it be useful for this patient? Would the patient need it? Did I start talking about the quality of care for this patient? Some organization says that they start asking the patient what matters to you. So we need to start this conversation with our patients to see what is the medication plan that is very suitable for my patient. Is the patient adherent to currently prescribed medication? Maybe I'm adding a new medication, not because the currently used one is not effective, but maybe because the patient is not using it. And by the way, from experience, this is a very common challenge that we see in our healthcare systems. If the patient disease is not properly managed, probably, for example, is the blood pressure is not properly managed, not because the drug was not effective, but maybe the patient is not using the medication as intended. So adherence to drug therapy is one of the first options I need to be questioning before I decide to change the medication, current one, to a new medication regimen. So when starting a new medication, again, consider it a trial rather than a permanent addition. Like when I start him on a new medication, just to try it for 1 month, 3 months, see the impact of this medication. Is it working with the patient? Can he adhere to it? There is no major side effect. And then if everything went fine, I'm reaching my goal, then I can give him a prescription for a longer duration, and I consider it as a chronic one. Do not start with a permanent medication for long term, and before trying it, making sure it is the correct medication, treating the correct disease for the correct patient. Follow up with the patient in a timely manner. Make sure to have your routine follow up with the patient. It doesn't have to be physically in the hospital. Virtual calls, teleclinics, communicate with them, post-discharge communication. All of these frequent communication with patient would help us to understand more what is this current situation, if he's using the medication, if it's really being effective, if it is safe, it is reaching our objective, or there is a changes has to be applied with them. Assess for effectiveness and safety at a follow-up visit. Whenever you see your patient, every 3 months, every 6 months, try to do your own assessment. Is it safe? Is it effective, or there is a need to change or minimize these medication? And this is very important to avoid auto refill of these prescriptions. So when you refill it with them, you do your clinical assessment, consider benefit versus risk or harm, then take decision to continue as a long-term medication or discontinue and keep it as a short-term management. So these are the cycles on how we need to manage our patient. Those are the steps when we need to see the patient and do our medication management therapy. Past medical history. Know your patient first. Know our previous medications, previous diseases. How is their previous compliance? If there is any other comorbidities that we need to be aware of. Assess all medications, as I mentioned, match medical disease, surgical, and history with everything the patient is currently receiving. Then do your benefit versus risk management or assessment. Do the adverse drug event history, if there is any interaction, if there is any allergy, time and magnitude of effect. Am I receiving the desired level of effect from this specified period of time? Then there is a very important other consideration is a treatment cost. Can my patient afford this medication? Because if he does not afford it, it means he's not going to buy it, and we'll go back to the first cycle that there will be no adherence to the medication. So very important to assess the situation, consider if there is other possible options, and if not, discuss this open with your patient to make sure they will be in compliance with this medication with no other constraints or not. And very important, goal of therapy. Where do I want to go and what do I need to reach? Then at the end, after understanding all those concepts, you have to put and document your plan. Your plan either to be a discontinuation, that this is not needed, continue the same treatment if everything is going fine as desired or as intended. And the other option is starting a new medication. As you can see here, starting a new medication could be the last option after exploring all other possible options. So this will be the process how we need to be looking at our patients. So medication reconciliation on transition of care. In the beginning, we covered the topic of polypharmacy, and I would like you to imagine with me a patient with a polypharmacy being admitted to the hospital or being discharged from the hospital. What would be a possible risk in your opinion? Now I will give you 2 seconds to think about it. A patient with 5-6 medications being admitted to the hospital. What could go wrong in this process? How smooth it can be? What are the risks that could happen when the patient is admitted? I am sure the first thing you would think about, I might be omitting one of those medications. I forget to prescribe it. Or I might be prescribing it, but with the wrong dose. Or I might be prescribing it with the wrong frequency. So these are very important questions you need to be asking yourself. Why medication reconciliation upon transition of care, upon patient admission, transfer, or discharge from the hospital is a very essential safety component for all patients and for our polypharmacy patients in particular. So then we need to start asking our 3 W's: what, why, and when. What to start, why to start it, and when to do so. So what is a transition of care? I kept on saying transition. So how can we define transition of care? It is when a patient moves between facilities, between one hospital to another, primary care, secondary care to tertiary care, or moving between sectors, private sector to public sectors, and staff members. Increase the possibility of communication errors. And I'm moving my patient also from like a regular floor to critical care area. I'm moving my patient from a floor to the OR, from the OR to recovery room, moving between sectors, moving between levels of care, moving between facilities. All of these we are as changing custody of the patient between one group of people to another. So now there is a possibility of miscommunication or improper communication. So this is increase the possibility of communication errors, which can lead to serious medication errors. And I am sure you are very aware of such type of medication errors. So again, we've been talking about medication reconciliation with polypharmacy patient upon transition of care. So what is medication reconciliation? It is the process of identifying the most accurate list of all medications a patient is taking, including name, dose, frequency, route of administration, and using this list to provide the correct medication for patient anywhere within the healthcare facility. So the number one is identifying your list. How can we identify our list? We need to write all the medications the patient is using and then include all the relevant information: name, dose, frequency, and route of administration. So most frequently occurring type of medical error is medication errors. And that's why we started to think about medication reconciliation. You will ask me, why is it important? It is important because we all know when reviewing literature, reviewing all reports that we've been looking around, starting from error is a human, we know from the Institute of Medicine, the error is a human report started to say that there is something wrong that we need to be looking for. And multiple other reports mentioned that medication error is the most commonly occurring error in the hospital setting or in the healthcare systems. So most frequently cited category of root cause and of root causes for adverse drug event is ineffective communication. And we consider that moving the patient from one sector to another or from one level of care to another, we need to be completely communicating all patient-specific information, including medication information with complete medication history. And then most very sensitive patient populations that a part of a process that is very weak process, link between the steps, the handover, when you move one patient from from the custody of one group of people to another, this is called a handover. So this is a very weak step that we need to be looking for and make it very strong and a healthy process. So there's multiple initiatives by multiple organizations trying to tackle this issue. There is like the 5 Million Life campaign from the IHI. There is the High Five Guiding Principles, the Medication Without Harm from the WHO, third, the Global Patient Safety Challenge, the Saudi Patient Safety Center. They have their own initiatives and recommendations. There's multiple from the Joint Commission, from the ASHP, and from ISMP Canada. And I can assure you, wherever you go in any country, in the safety organization of this country, there is multiple initiatives about safe medication practices and having the medication reconciliation a very integrated part of those medication safety recommendations. So how do we justify the need for medication process that address transition of care? There is multiple studies, and those are a very simple number of those studies. If you like, if we have more time, I can share with you multiple other studies talking about the impact of medication errors and patient harm. Like here, one study indicated that a rate of medication error in a 6-month period decreased by 70% after implementation of medication reconciliation process at all phases of hospitalization. Can you imagine the decrease by 70% is something very valuable and very important. Another study, they found that 94% of patients had orders changed after ICU stay. By reconciling all pre-hospital ICU and discharge medication orders, nearly all medication errors in discharge prescribing were avoided. So here they were able to avoid medication errors by transition of care. Like another example of other initiatives, Sibahi, Sibahi is our Saudi healthcare accreditation organization. It is the Saudi Central Board of Accreditation for Healthcare Institution. Under Sibahi, we have the chapter for medication management chapter that describe the best practices for medication management. And we have a specific standard for medication management about safe medication prescribing, ordering, and the transcribing of medication orders are guided by a clear policy and a procedure. So we need to have a policy how to do safe prescribing across the medication use process, prescribing, ordering, transcribing of medication, along with dispensing and administering. And there is another standard talking about medication reconciliation is conducted at the time of admission and discharge. So here, these are another recommendation from the Joint Commission, MMU for prescribing, ordering, and transcribing are guided by policies and the procedure. Another one for about patient record contain a list of current medication taken prior to admission. So these are part of the MMU, medication management and use chapter. Another one for the complete discharge summary is prepared for all patients. Then discharge summary contains significant medications, including discharge medication. Patient education and follow-up instruction are given in a form of language and that patient can understand. Then the last one, follow-up instruction are provided in writing. So all of these are standard written by different organizations talking about safe medication prescribing upon admission and upon discharge. So required step in medication reconciliation process. I've been talking about medication reconciliation. How can we conduct it? How can we ensure conducting a proper and comprehensive and efficient medication reconciliation? As I mentioned in the definition, step number 1 is creating your up-to-date or most accurate list of the medication the patient is currently receiving. So prepare your list, initiate your list, then reconcile the list medications with the new orders. See what is the patient is receiving and what are the new orders the patient will be receiving, and do your review, your assessment, and your reconciliation. So this will avoid omission. This will avoid duplication. This will avoid addition of any unnecessary medication, or then you will add something is necessary. You can do this, and then you do the adjustment if any adjustment is needed. Then update list as order changes during the episode of care. And if the patient is in hospital and there were some legitimate changes that the patient shall be taking, then the list has to be updated based on the most accurate and up-to-date list. Then communicate updated list to the next provider and patient as required. Then if the patient is moving from one hospital to another or from one level of care to another, we have to communicate this list. Or if the patient is being discharged or out of our system, out of the hospital, we need to share this list with the patient so they would know what patient they shall continue taking after leaving the hospital. So identifying and resolving discrepancies, this is the core concept of doing reconciliation. When you are reviewing the current medication list and the new orders, you have to do this medication reconciliation and try to look for any possible discrepancies and try to resolve this. The discrepancies found between admission medication orders and the discharge can be divided into three main categories. Number one, intentional discrepancy. Yes, I mean to have this discrepancy because I want to change the current medication the patient is receiving, either changing the dose, frequency, or adding a new medication. Here, as they define it, the prescriber has made an intentional choice to add or change or discontinue a medication based on the patient's plan of care, and their choice is clearly documented. And also, please remember the part of documenting the intention for change or undocumented intentional change. It was intended to be done, but it was missed and it was not documented. So this has to be corrected, or it was done by mistake, the last one, and it was unintentional. By doing the reconciliation, we will correct it and we will go back to the primary list the patient shall be receiving accurately. For an unintentional discrepancy, the prescriber unintentionally change or add or omit a medication the patient was taking prior to admission. Unintentional discrepancies fall into two main categories. Either omission, we forgot to prescribe the medication to the patient. Like I had an example that I've seen in my practice. A patient was chronically using thyroxine. She's a hypothyroid patient, and she should be receiving thyroxine as for a lifetime. When she was admitted to the hospital, they forgot to start her on her levothyroxine. So after around 2 to 3 weeks of admission, the patient case started to be very deteriorated because she's not been taking her medication, and the error was discovered after the patient get partially harmed from not receiving her medication. Or the discrepancy could be commission, adding a new medication the patient should not be receiving. And also this is something common, and we see it in practice. When you admit a patient, you by mistake start him on a new medication, even that he used to take it before and it was discontinued earlier, or it is not his intended medication, or it was intended for another patient. These scenarios happens in healthcare system, and by applying a proper medication reconciliation, these all can be corrected and avoided. So you will ask me, who should do it? I don't know today who are my audience and from what profession they are, but I am assuming I will be having from all different healthcare provider disciplines. I will be having a nurse, maybe a pharmacist, I'm sure, I think so, and a doctor's maybe also. So whom you think the responsibility to conduct medication reconciliation is the responsibility of who? Is it a nurse? Is it the pharmacist? Or it is a doctor? The answer is it's everybody's responsibility. And yes, this is the answer, because we are all responsible to ensure safe medication prescribing, dispensing, and administering for our patient. But it differs from one hospital to another based on your hospital system and or hospital policy. But it is the responsibility of all. So everyone is responsible for ensuring that medication are used safely. Each profession has its own unique skill and knowledge. Good collaboration between various members of the healthcare team bring together those skills to improve the quality and safety of patient care. So start with the first step of medication reconciliation, taking the best possible medication history. We call it BPMH, best possible medication history. So this is a very critical step and the skeleton of doing a safe medication reconciliation. The goal of this is to obtain complete information on the patient pre-admission medication regimen, including name, formulation, dosage form, dose, route, frequency, indication, allergies. And allergies is something extremely important because if we do not document allergy, we might end up having patient being prescribed and administered a medication that he is allergic for. And you can imagine the consequences of this happening to our patient. Then try to use at least two sources of information. One source might not be sufficient. So the sources could be definitely the patient himself, or if he's a pediatric, or he cannot communicate, his guardian or his family member or his caregiver. Try to check the previous medication history in the hospital documents. Try to receive the bottles. Ask the patient to bring the bottle with him to the hospital, the pills of his bottles. Try to read it, read the instruction. If the patient has any medication list from previous admission or from previous hospital, try to bring it and then compile it all together and try to come up with the most accurate medication list. And this has to be done in a proper, timely manner. Some organizations say it has to be done within 24 hours of hospitalization to avoid that you are not missing a critical medication for those 24 hours upon patient admission. So taking the best possible medication history, if starting point is a medication list, and this is something very important, review and verify each medication with the patient. Assume all lists are inaccurate. And this is a very important term because the medication list coming from your specific hospital or other hospital might have been changed in between that is not really reflected and documented in this list. Try always to consider this is not an accurate list until I verify it and until I confirm it is the most accurate list. If starting from scratch, if you do not have a medication list, you can have different sources of information. Consider the following prompts. What medications do you take at home? Ask the patient. What medication do you take every day? And regardless of how you feel, that it doesn't depend if I have pain, I take it or no. If I have nausea, I take it or no. If I have fever, no, it has to be taken on a daily basis. Disregard how you feel. Which medication do you take only sometimes? So try to differentiate. What are the indications for these sometimes? When do they use it and when they do not? And then start to fill in gaps about doses, frequency, formulation, route, etc. if any other information is needed. So these are some tips, and I would like you to go over it quickly on how you need to create your best medication the patient is receiving. Be proactive by asking the questions, prompt questions about non-prescription categories, which is something very important. You can be preventing a serious harm and drug-drug interaction if you ask the patient about a non-prescription medication, or we call it in some countries over-the-counter medication. Example, herbal medication, vitamins, a lot of traditional remedies the patient might be receiving. Then prompt questions about unique dosage form. You have, if you're receiving eye drop, inhaler, patches, and by the way, a lot of patients or a lot of caregivers tend to forget about patches because they do not see it. They cannot visualize it. And you can, I'm sure you know the impact of harm if the patient is receiving a patch and we do not change it, or we apply a new patch, or we do not consider the medications in this specific patch. Or maybe a spray. Do not assume patients are taking medications according to prescription. I read on the bottle, he should taking one tablet every 6 hours. Did I ask the patient? Did I confirm or just depending on the sticker on the medication bottle? And very important tip when you are asking a question, try use open-ended question. Tell me about your medication. Tell me how you use it. You don't start with sharp-ended questions. This is something very important. So we can trigger the patients to talk about how he is or she is using the medication. Use medical condition as a trigger to prompt consideration. How you manage your blood pressure, how you manage your diabetes, how you manage your pain. So try to tell them how you manage those symptoms so they can talk about their medications. Consider patient adherence, and this is something very important. Ask them how they use it, because if they are not using it, so they are not taking it, try to go back and evaluate the adherence challenge. Verify accuracy, always validate by more than one source, as I mentioned earlier, the patient, previous provider, medication list, the community pharmacist, the family, a caregiver. This will help you to have a complete picture of the patient medication he's receiving. Obtain community pharmacy contact information, try to get the number so we can clarify things with them, and use trigger sheet, a systematic process, interview guide, try to write this and document it, include efficient order, optimal phrasing of questions, and the prompt for commonly missed medications. So these are some tips. It's very recommended to use it when you are doing your best medication list. This is coming from ISMP Canada. So we need to go for multidisciplinary approach. Upon patient admission, admitting physician responsible for documenting and comparing home medication list and deciding what medicine to continue. Then we will have our other services in the hospital. Nurse and pharmacist will review the list. Then upon transfer, physician on transferring and accepting teams review medication dosage, and when administering it, the nurses shall review it. Then discharge, pharmacist, physician compare outpatient list and inpatient list, review medicine instruction with the patient. So now we have a comprehensive approach through multidisciplinary approach on how we need to create this list, ensure updating it, communicating it, and at the end, sharing it with the patient to ensure their understanding and compliance. So we need to have a shared vision on what we need to be looking for. Patient and healthcare professionals will rely on pharmacists to provide leadership in designing and managing optimal patient-centered medication reconciliation system. We all believe that when you talk about medication, you start thinking about a pharmacist or a pharmacy. So now we need the help of our pharmacists to design the safest possible medication reconciliation system, since they are the medication expert, and I think everybody's believe on this. Pharmacists have distinct knowledge, skills, and position in the medication use process to facilitate and implement effective medication reconciliation tools for patient and in the disciplinary team to use it and to utilize it. Pharmacists will lead a change in achieving safer and more effective medication use by educating patient and healthcare providers regarding the benefit and limitation of medication reconciliation process. So these are the pharmacists are frequently integral in the medication reconciliation, yet may not be the best solution because in some organization, they don't have enough pharmacists to do all of this. That's why I mentioned in the beginning that we need to look for our hospital system to see what is the policy, what is the best suitable for your organization. Try to set your policy and adhere to it. And always a pharmacist can be a great asset and support for this process. In some occasions, they assign a pharmacist to be for only high-risk population, like for transplant patient, for some oncology patient, for some metabolic patient, for some pediatric patient. Try to select your high-risk area or high-risk patient population and assign a specialized pharmacist to do their own medication reviews and or reconciliation. So the research suggests that the following can be a high-risk population: older age, between 55 to 80. I disagree 55 is an older age. What do you think with me? Do you think 55 is an old age or we need to extend it to be bigger than 55? Then polypharmacy, if the patient is receiving 4 medications until 13 medications. And if the patient have more comorbidities, like the patient is, God forbidden, is a cancer patient, is a disabled patient, at the same time he has some diabetes, he has some hypertension, he has some other chronic disease, he went through multiple surgeries, motor vehicle accident. Those are some other comorbidities that we need to be considering when classifying a patient as a high-risk patient or a non-high-risk patient. Other information to be aware of: medication side effect. Look for your medication side effects, special instruction for taking each medication, how the patient shall be using it, with food, without food, is it to be stored in the fridge, outside the fridge, which medication might be discontinued, so they need to be aware about it, or might be added to the medication list. And always consider the risk of having look-alike and sound-alike medications. Look-alike, sound-alike medication is considered one of very challenges, risk areas in the healthcare system. We have multiple medications with similar name, multiple medications with very similar packages that us as a healthcare provider are getting confused with it. So how is it with the patient? I really expect them to be confused with these similar names or similar packages. That's why we need to be considering this when reviewing our medication list and providing accurate and appropriate training and counseling for our patient. So now we are in the step of implementing medication reconciliation and a very important strategies for success. So number one, refer to the arrival list when writing medication orders for admission, transfer, and discharge. This will be your master list when the patient arrives to the organization, to look for all his medication and the details of this medication. Compare the arrival list with every medication ordered at admission. Are they the same? Is there any differences? And also upon discharge, identify discrepancies and clear it, whether it is intentional or unintentional discrepancies, as I just mentioned a while back. Then address all those discrepancies, take the correct decision, and then reflect all of these on the final corrected and updated medication list. Verification, collect of medication history. Clarification, ensure the medications and doses are appropriate. And then, as I mentioned, documentation. So performing robust, thorough, and accurate medication reconciliation during transition of care, it involves interprofessional collaboration. As I mentioned, it is the responsibility of all, a pharmacist, a physician, and a nurse. Integrating medication reconciliation into the discharge summary. Whenever you are discharging your patient, make sure to put the final list you want your patient to be discharged on. And then combining reconciliation with medication counseling with the patient. And if I did all of those efforts and I did not reach the patient with a language he can understand me, to make sure he will take the medications as intended, I will be wasting all of these efforts. So please always give an extra focus on the part of communicating with your patient and providing the proper and efficient medication patient counseling. So recommendation for reconciling medications at admission: collect complete, accurate pre-admission medication list. You need to collect by including all information, including dose and the frequency. As I mentioned, validate the pre-admission list. Assign a primary responsibility for collecting the pre-admission, whether a pharmacist, whether a nurse, whether a resident. Try to have it in your system, sufficient expertise. You don't bring a new grad with minimum communication skills and ask him to do this, because you will end up having an inaccurate list for your medication list. This is coming from the JCI summary of safe practices. And write accurate admission orders. So this will be reflected in your admission orders. Reconcile all variances. As I mentioned, compare the pre-admission list with the admission medication summary and try to clear any discrepancy. Then provide continuing support and maintenance. Make sure that you reflect all the changes in this list and deliver the correct information for your patient. Now I will be moving to implementing the WHO 5 Highs for medication reconciliation. The first step is to determine what needs to be done. It's very important to know what needs to be done for our patient, who should be involved, and what are their roles and responsibilities. You cannot keep the medication reconciliation open without a clear assignment. Then everybody will assume that other discipline will do it. So we need to have a very clear, well-designed, structured assignment on who is responsible to do what, when, and how, and what is the documentation style in our organization. So then we need to see what is the timeline for implementation. As I mentioned earlier, usually within the first 24 hours, so to avoid missing any critical medication for our patient during the first 24 hours. What are the major milestones and deliverables along the road to for full implementation? Who should do what, then who should review what are they going to document, how they are going to finalize it? Should we pilot the study or should we pilot our design or our system? Now, if you are creating a new medication reconciliation, how we want to design. I was thinking to ask you a question for my attendees, please. In your organization, do you have a medication reconciliation implemented? I need you to think about it. And if you have the answer, please write it to me in the chat box. And if is yes, do you have a policy for this? I want you to think about it. And if you have a policy, please write it to me in the chat. I would like to look at it soon. And if you have a policy, if you have a process, if you have a policy, who is responsible to do it? Is it a pharmacist, a nurse, a physician and a nurse and a pharmacist? I would like to know. Also, please write it to me in the chat box. If you have a clear assigned role to do who to do what. And if not, are you considering creating a medication reconciliation in your organization? Also, I would like to know if you are looking for this, if you want to apply medication reconciliation, can you start doing this from today? What are the challenges? I will take all answers and I will discuss it at the end of the session if we have enough time to do so. Please think about these questions I ask you now. Go to the chat, write it, document what do you think or what do you have so we can have time to look at it and discuss it. So how is a full, successful, and sustainable implementation achieved? From your experience, what was the key for success? And at the same time, think about what was the reason for failure if it didn't succeed. So you can learn from failure and improve it in your next trial on how to make a very sustainable, effective medication reconciliation. So here I can share with you key steps to start. For those who did not have medication reconciliation in your organization, there is a very basic key steps that will help you to succeed initiating this project. Number one, secure senior leadership commitment. You need support, you need leadership, and I really truly believe in the leadership role in making each project effective and reaching the goal or the intended goal. Whom in your organization is toward patient and medication safety? Who is a lead that will help you to achieve this and try to get their input, their support, and work with them to start your project. Then formulate a team. The team shall be consistent, as I mentioned, a physician, a pharmacist, a nurse that we need to sit together. In some occasion, patient relation personnel to be sitting with us, helping us on how to talk to patient and how to make the information clear to patient. Develop a working plan, process mapping, sit together and try to imagine your design, your process, put it together, do your process mapping, plan your process, then define the problem by setting the aim. What do you want to reach? Do your baseline data collection. What is your current situation? And submit your baseline data. Try to see where you are now. Then start small. I don't expect you to start across the organization by all admission, transfer, and discharge. Try to start with the first step, test your achievement, test your processes. If it's fine, you can proceed, or if you need to do any modification, you can do the modification. And by doing this, you will be building your expertise. Now you will be having more experience launching this new process, and then you can continue until you achieve your goal. Evaluate improvement being made. If it's effective, proceed. If there is an area for improvement, go back, re-evaluate, revisit your list, revisit your resources, revisit your policies, and then you can do the required improvement. Collect and monitor data, then spread throughout the organization. This is a basic plan, do, check out PDCA cycle, performance improvement cycle, just to give yourself a stepwise steps on how to initiate a medication reconciliation in your organization. Then there is multiple training and competency program for students and healthcare professionals on how to do it. Make it happen. Design a process for developing the list. Try to help people who are going to be doing the process and help them. How are they going to design the list? Make it available, using it, updating it, and providing to patient and next provider physician. Develop a tool, develop your policy and the procedure, train your staff, and then monitor the process. Look for opportunities for improvement and improving your process. Competency development, it could be knowledge, skills, and abilities. Understanding of medication reconciliation procedure. How are we going to do it? Ability to conduct patient medication history, talking to your patient. You need to speak the same language, the same accent in some occasions. Ability to use all available resources to gather patient medication history, from the medication bill bag, from the patient himself, from the guardian, from the community pharmacy, from previous hospital medication list, from our medical record. Try to use all of those resources like a triangulation theory, so you can achieve the best, most accurate medication list. Ability to identify medication discrepancy. You need to know how to review the current list with the other list and identify any discrepancy or failure. Ability to document in the medical record, and ability to troubleshoot discrepancies identified. Then you need to be able to know, I was able to identify this discrepancy, how to identify it, how to take the correct decision for my patient. Prerequisites like background, knowledge, skills, abilities required to staff prior to participation. By the way, there's multiple reading material, courses, maybe YouTube videos talking about how to interview or some interview skills, using probing questions, open-ended questions, good listening skills, asking the right question at the right time to the right person is some skills that you need to be learning before start interviewing your patients, considering the confidentiality, respect others' opinions. And this is something very important when you do patient interviews. Foundational understanding of required component for a complete and accurate medication history. Training and education that will be needed, didactic and experiential training, independent review of guidance, document regarding medication reconciliation procedures, preceptor available for questions. So someone has to be very expert in the process. Try to do this didactic training for people who will be involved in the process, and they need to be available. Then you can do this later on by trial and by experience. Observe the pharmacist complete one medication reconciliation, perform medication reconciliation assessment with the preceptor. Make sure that the person involved in the reconciliation process is knowledgeable to do it. So how competency will be assessed or measured? Using these observational processes, demonstrate proper method of obtaining medication list, conduct medication history interview, identify medication discrepancies, and identify to communicate and troubleshoot identified discrepancies. Method of assessment, direct observation, performance threshold. You can put your own threshold, like for example, successfully completing more than 90% of medication reconciliation competency checklist. So this will be, they can pass the competency assessment. Competency example, there is some examples of how you can do your competency for the staff involved in the process, and those are part of the competency information or items that you need to be checking your staff doing it properly. Challenges and lessons learned. I personally, I was involved in updating, creating medication reconciliation in our hospital. We used to have it on a paper form. Then when we moved from paper to electronic, we used to make it on electronic form. The compliance was always challenges, reviewing the process every cycle, every month, in some occasions, putting our target, fine-tuning the process, involving more expert in the process was a very interesting story, and I can see it a success story. And it never ends, by the way. Don't feel frustrated if you did not reach your target quickly. Sometimes it takes you years to reach your target. Just be patient. Know your novel goal of patient safety, preventing harm, and I am assuring you, you will have dozens of methods to improve so you can reach your goal. But definitely there is multiple challenges, multiple difficult stories that I am sure you can overcome by learning from our experience, learning from other experiences, and continue improving your system. As I mentioned, it does not come with easy price. It needs time, it needs effort, it needs leadership support, it needs commitment so you can reach your goal. Often no clear owner of the process, because there is multiple occasions, and I see it in different hospitals because I go for surveys in different hospitals. When I review their policies or their processes, I see that there is lack of ownership. Who is responsible to do what is not clear for them. So this could be one of the challenges and failure points. A lot of people would fail in it. Time constraints. We don't have time to do it. And believe me, we don't have time to do multiple things, but we do it. So if you decide to do it, you will find a good time to do it. Difficult to identify accurate source of information, which is, I truly understand. That's why we mentioned use multiple sources of information. Community pharmacy, if you can communicate with them, previous medication list, patient family, patient himself, previous document, and try to use triggering questions so you can get it. But I'm sure there's occasions that you don't have enough resources of information. Poor health literacy, patient does not know or cannot tell. Communication challenges, patients do not want to admit what they have been taking, some confidential or different beliefs or understanding by patient. Labels on bottles are often outdated or incorrect or peeled off, not clear to read. Patient may take medication differently than prescribed. As I mentioned, make sure to ask them how they are taking it in reality, not how is it written on the papers. Medication lists are often inaccurate. This is something very important always to consider. And patients often forget several types of medication. They forget that they are taking medications that in the fridge, they tend to forget about it. Or they are not taking it by mouth, topical, or as I mentioned, patches. Those are frequently being missed by their patients. So please always to try to think about those type of medication, ask questions about it, so maybe the patient will remember talking about it. So these are the sources of confusion of patients regarding medication, multiple names with the single drug, like the patient is using Lasix and furosemide. They might be confused. Failing to instruct patient about medications taken at home that were not written for discharge, switches between formulary version in the hospital, changing the doses, strength, and the frequency without sufficient understanding by the patient as why we did so. So whenever we do any change, the patient needs to be informed. We did this because of this reason, because otherwise they will not know about it and they will not comply with it. The stress of transitioning through the healthcare system, moving between one level of care to another, from one system to another. Language barrier, this is something very important to consider, especially if you are working in a multinational centers where we talk different languages and different cultural belief. This would be a challenge that you have to consider. Relationship with the healthcare clinicians who is obtaining the history. Are they properly communicating together? There is a mutual respect. This is something very important to look for and ensure having it. And then, as I mentioned, interviewer skills. Try to build your own skills doing these interviews and asking patients about it. And one of the best options we need to talk about is health information technology. using electronic system. And I am sure now multiple organizations are having electronic system for medication prescribing, dispensing, and administering. A consensus statement issued by the Society of Hospital Medicine highlighted the power of health IT. Always consider smart systems to do your reconciliation and do your electronic medical record about it. The consensus statement by the SHM recommended an integrated and transferable personal health record, so you can share information between one center to another. This record must be compatible across all settings, primary, like regular floor, critical care, wherever the patient is moving, they can see the same set of medication list. At the end, a note of caution: hospital-based medication reconciliation at care transition frequently identifies unintended discrepancies, but may have no clinical significance. Bundling medication reconciliation with other interventions aimed at improving care coordination at hospital discharge hold more promise. So we need to put all efforts together, all possible medication safety initiatives together, so we can reach the best possible safe medication practices. Medication reconciliation can be bundled with other intervention like individualized counseling of patient, coordination of follow-up appointment, post-discharge telephone calls, involvement of a care coordinator or nurse discharge advocate. Best practices in medication reconciliation: patients should participate in medication reconciliation process, encouraged to keep up-to-date list. During discharge process, medical staff should ensure that patients are educated about any changes in the regimen. Medication reconciliation helps patients recognize they are responsible for their own health and the safety of their own self. Medication reconciliation issue is not going away, so it will continue doing medication reconciliation. The admission process is complex. The discharge process is twice complex. Because think about it, the patient in the hospital is under the care of everybody: a physician, a treating team, a nurse, a pharmacist, doing review and administering them the medication. And suddenly he will go home with this big white bag of medication. And I consider him being able to take care of everything at home. Without proper training, counseling, information, this will not happen properly. So please consider doing reconciliation at discharge with complete and accurate patient counseling. No one likes to be asked the same question twice. So try to ask your patient all your questions together and once. No list is perfect. So try to do your best to have the best ever, but it cannot be perfect. There is no quick fix. You cannot go tomorrow and apply it and you succeed. Communicate, communicate, communicate. So our lesson today is minimizing communication failure by frequent, complete, accurate, timely communication. Be flexible and listen to the concern of the staff and of the patient. Multidisciplinary support is essential. To be successful, absolutely must demonstrate the value. This is not just filling out another piece of paper. Our goal is not the piece of paper. Our goal is the safe medication for our patient, and this has to be very clear. So these are some very important references. You can look at it, learn from it, and use it for your future project and for ensuring safe medication reconciliation in your hospital. I wish I was able to finish on time, which is, yes, I expect. And if you have any questions, please let me know.
Thank you, Dr. Salma. We can look to the chat as you asked our audience a couple of questions regarding if they have medication reconciliation process. I saw many answers. The answer would be yes. And
Excellent.
The second question was related to the policies. I saw only one answer. They have policies, and who involved on the medication reconciliation. Most of the answer it was the pharmacist and the physician and a nurse.
Excellent. So I'm happy that I have those answers. So did we have any questions saying no, we do not have medication reconciliation? Did we have this
Actu-
answer? I can see, yes, there is no's. There is some no's here in between.
Yes.
So those who answered no, I think this will be your golden opportunity to start working on your hospital medication reconciliation system. And I believe you learned something today, and you can go back looking for the references we provided and start your step one. We are all here to help you, and you can learn from our presentation today and try to create your own medication reconciliation process in your hospitals.
Yeah,
Any
Dr.
other
Salma,
questions?
if you allow me, we have a couple of questions. The first question is, does the medication reconciliation include patient on medication that he may be taken before coming to hospital? Also, does it include herbal medicine being taken by him?
Yes, definitely. Thank you for it. This is a very important question. Medication reconciliation or the best medication list has to include all of those medication. As I mentioned in the beginning of my of my presentation, it has to to put everything and then start discussing it with the patient and know why he is taking it, how he is taking it, avoid any unintended duplication or unintended medication. Even for herbal medicine, by the way, we know we are healthcare providers and we know some herbs would interact with some medications. So knowing the patient, what he is receiving at home, either an OTC medication or patient-owned medication, at the end it's a medication. It's a chemical that might be interacting with the medication I'll be giving him in the hospital. So put a complete list and then review it with the physician to decide what is the best for your patient and then share it back with the patient. And the answer is yes for your question.
Yeah, and the second question, medication should be reviewed by consultant, not by resident. Is this correct?
Usually the resident in some hospital would start creating the list. But as we all know, the patient is the responsibility of the whole treating team under the consultant supervision. So in creating a new medication or changing a regimen, it's much better to be coming from the treating team as a whole, which is supervised by the consultant, not by the resident. Yes, that's correct.
Yeah. The third question, in ambulatory pharmacy setting, how can we apply medication reconciliation?
Ambulatory pharmacy, if the patient is taking his medication from a specific ambulatory pharmacy, not using more than one ambulatory pharmacy, this can be done. But at the end, when you have a patient coming to you in the ambulatory pharmacy, you can have started chatting with your patient, asking them what medication he is receiving, if he's taking it from other organization, try to guide your patient. But I'm not sure if we can do it in the ambulatory pharmacy alone. Ambulatory pharmacy, as I mentioned in my presentation, could be a source of information for the hospitals to have a complete medication list, not to do it without this community pharmacy.
Yeah, I think the medication list will be helpful in ambulatory care rather than reconciliation. And this is an interesting question. Can we utilize the artificial intelligence in medication reconciliation?
Definitely we should be. But now we are looking for new generations to start telling us how artificial intelligence will help us. Like if you can see the patient is coming frequently to this pharmacy to take this medication, it means he's diabetic, probably he's hypertensive. There is multiple ways you can searching Google for certain specific type of medications. All of this comes under the artificial intelligence, and I'm sure we can use it in multiple ways, the artificial intelligence. I'm sure in the future, there will be more applications on our iPhones, Androids, helping us to create. And now currently in my hospital, I am working on a program asking the patient before they come to the hospital, using the hospital application to review the medication list, write their comment, and if they have any medication from outside the list, just to scan the barcode of this medication, so it will capture a photo when the patient will go to the hospital appointment. Physician can review it and make sure that everything is accurate when the patient comes to the clinic. So definitely it should be used.
Yes, and this question is also, is a beauty supplement including in the medication reconciliation?
Well, it depends. If the patient is taking oral multivitamin, it depends how you define beauty supplement. Is it like a Botox injection? I'm not sure. It's good to talk about it with your physician. Or it's an oral supplement, or sometimes they take oral multivitamin, oral collagen, oral medication that might be interacting. Here, yes, you need to communicate with your provider and include it in the list. It depends on what kind of beauty supplement you are talking about.
Yes, finally, I
Very
think there's
interesting question.
yes, it is. And this question, do we consider the combined drug as one or two in case of polypharmacy? Combined drug?
Actually, it depends. It's combined drug. It's one pill the patient is receiving, but in reality, it's two. So I think you have the option to take it because sometimes, and I have it like often in my pharmacy, if the combined is not available in our current pharmacy, we give them two medications that equal for one. So I think you can consider it as two because it will increase the risk of drug-drug interaction, side effect, and the patient might go to the pharmacy. Like for example, if you don't have the combination medication, pharmacists might give him each chemical entity by separate bill or separate tablet. So I think it can be considered as two. It depends. It's not like a real major matter. But if I'm in your shoes, I will consider it two medication, not one, because more side effect, more adverse drug event, and possibly more allergic reaction are the drug-drug interaction.
Yeah. Okay. Yes, on the end, on behalf of the Saudi Patient Safety Center, we would like to thank you, Dr. Salma, for the amazing presentation, and also for our audience. And we are so sorry if we not answer because there is a lot of questions. We
there is some limitation. Yeah.
Yes.
Maybe in future sessions.
Yeah, for sure, inshallah. As a part of Saudi Patient Safety Center effort to provide you with the timely topic and interesting speakers, we would appreciate you if you will fill out the evaluation survey, which will be sent to you by the email. Thank you again. Thank you, Dr. Salma. Thank you for our audience to joining to the webinar. Thank you. See you soon, inshallah.
See you soon.
Thank you. Thank you.